Hello friends, Dr. Kofi here again and welcome to my YouTube channel, TutorMed, where everything medicine is simplified. In today's video, we will have our second tutorial in surgery, and as usual, it is a clinical case discussion, and so if you are new here and are preparing for any licensure exam, you might want to consider subscribing and putting us on post notification to get notified anytime we upload new videos. Alright friends, grab your notepads and let's begin. Very good, and so let's get straight to our clinical case. The question says, you were in the health facility when a 26-year-old boy was brought in by his friend with a sudden abdominal pain associated with vomiting, and the abdominal pain was severe in the right iliac fossa. There are 6 questions for this clinical vignette. The first question says, mention 3 differential diagnoses of this presentation. And so as usual, some seconds to think through this question. And so for this clinical question, the relevant information here are the fact that we are dealing with a 26-year-old male who came with sudden abdominal pain, and this abdominal pain was associated with vomiting, and the pain was particularly severe in the right iliac fossa. There are a lot of differential diagnoses here. In fact, all causes of acute abdomen are potential differentials because this is a typical case of an acute abdomen. And so here, the differentials are 1. Acute appendicitis, and that comes first because of where the severity of the pain is, the right iliac fossa. It may not be acute appendicitis, but it is likely. Acute appendicitis is likely. Then the second differential we would consider is a perforated peptic ulcer. The third differential we'll consider is a typhoid ileal perforation. Then other differentials include right testicular torsion, right ureteric colic, it could be acute intestinal obstruction, etc. So any potential cause of acute abdomen can explain this boy's presentation. But using the clinical vignette, it appears acute appendicitis is likely. Then it may be perforated peptic ulcer or typhoid ileal perforation. We've been asked for 3, and so we stick to 3. Now, the second question says, mention 5 investigations you will carry out. Now, you agree with me that there is no particular diagnosis we are dealing with, and so in my opinion, we can write any investigative procedure which is able to evaluate any of the 3 differentials we've listed, or evaluate any likely differential in this patient that we did not list, like testicular torsion or acute intestinal obstruction. And so the investigations we can do include an erect plain chest radiograph or a plain chest x-ray, which is done in the PA view. What are we looking for? We are looking for air under the right hemidiaphragm, which when present might suggest a perforated viscous, either from a peptic ulcer perforation or a typhoid ileal perforation, or even from blunt trauma. Then we can do an erect and supine plain abdominal radiographs. We are looking for radiographic features of acute intestinal obstruction, like multiple dilated loops of bowel, multiple air fluid levels, etc. Sometimes the X-ray can diagnose radio-opaque stones in the gallbladder or in the ureters. Then we can do a full blood count. Because he might need surgery, we need to know his baseline HB at least. Then we can do an abdominal ultrasound scan or a CT scan. The ultrasound scan can tell us whether or not the appendix is inflamed. The CT scan again can also tell us about the appendix and can also diagnose ureteric stones. Then we need to do a blood urea electrolytes and creatinine for him, because If you are preparing him for surgery, we need to know his electrolyte balance and then his renal function. So quickly we need to run that for him. We need to do tests like sickling, HB electrophoresis if necessary, but sickling is enough. Then we need to do urine RE for him as well. Some other investigations we should be doing is grouping and cross-matching against units. Since he may need surgery, we don't know the amount of blood he might lose, and so we need to secure blood for him. Then another investigation we can do is a color Doppler scan of the scrotum if testicular torsion is very likely in this patient. Very good. And so let's see the third question in this clinical vignette. The third question says, list 2 medical and 2 non-medical causes of acute abdomen. This question presupposes that not all acute abdomens require surgical intervention. There are some causes of acute abdomen which are even psychiatric in origin, medical in origin. And so let's go back to our question. And so for the medical causes, beginning with the medical causes, we have peptic ulcer disease. So if someone has an acute exacerbation of peptic ulcer disease, he may have a very severe abdominal pain which might mimic a surgical abdomen, but it is still acute abdomen. A patient with diabetic ketoacidosis may have features of acute abdomen. Gastroenteritis is also another medical cause of acute abdomen. Then mesenteric ischemia is also a cause of acute abdomen. So in sickle cell disease patients, if their sickle cells obstruct the mesenteric vessels or the vessels of the GIT, it may cause vaso-occlusive crisis of the GIT and give you pain in the abdomen. Sometimes patients with atrial fibrillation can also throw an embolus and cause mesenteric ischemia. Then typhoid fever can also give you a medical cause of acute abdomen. And when it comes to the surgical ones, we've mentioned acute appendicitis. You can have acute pancreatitis, which is inflammation of the pancreas. It could be a typhoid ileal perforation like we've already mentioned. Now we can have blunt abdominal trauma. Someone just kicked this boy's abdomen. We don't know, we don't have that history, but that can also cause acute abdomen. We have intestinal obstruction, also a cause of acute abdomen. We can have testicular torsion, ureteric colic, acute cholecystitis, a whole lot. And so please do not forget to support the channel by liking and sharing the video, and then subscribing to our channel if you have not done that yet. Now the fourth question in the vignette says, what is your definite diagnosis? Now in this patient, 26-year-old boy coming with abdominal pain which is severe in the right iliac fossa, the most likely cause among the 3 differentials we've listed is acute appendicitis. Although acute appendicitis pain may not begin suddenly, typically it begins as a vague periumbilical pain, and then within a variable amount of time, the pain migrates to the right iliac fossa. But the fact that the pain is very severe in the right iliac fossa makes acute appendicitis likely in this patient. However, this is a diagram I want to show something here, that sometimes perforated peptic ulcer disease can mimic acute appendicitis. Now, in perforated peptic ulcer disease, if there is a small leakage, maybe the ulcer has perforated and then the leakage occurs slowly such that the gastric contents trickle down the abdomen and then pass through or gravitate towards the right iliac fossa, you might have a right iliac fossa pain and tenderness that would mimic appendicitis. However, the pain is from a perforated peptic ulcer disease. And then, although not so reliable, in a perforated peptic ulcer disease, the pain is maximal at the tenderness is maximal at the epigastric region, and appendicitis, the pain is maximal in the right iliac fossa. And so I wanted to point out that sometimes a perforated peptic ulcer disease may mimic acute appendicitis, and the mechanism is that if you have a perforation and then it has been partially sealed off by the omentum or the liver, and then you have a little dropping into the peritoneum, it might gravitate towards the right paracolic gutter. That is a space that is lateral to the right colon, the ascending colon, and that may mimic acute appendicitis. Now, the fifth question says, how will you confirm your diagnosis on physical examination? The instruction is physical examination. And so, in acute appendicitis, the confirmation is that you would have tenderness and rebound tenderness located at McBurney's point. And this is a picture showing McBurney's point. It is the point between the medial 2/3 and the lateral 1/3. If an imaginary line was drawn from the anterior superior iliac spine from that place to the umbilicus, so that is the region represented by the number 1, and so that is McBurney's point. And if you have tenderness and rebound tenderness located there, maximal at that point, acute appendicitis may be likely. Now, there are other signs we can elicit in a patient with acute appendicitis, although they are not so sensitive in these patients. One of the signs is called the Rough-Sink sign. And so, a positive Rough-Sink sign, what is that? So you palpate the left lower quadrant of the patient's abdomen, and the patient feels the pain on the right. If that occurs, then the patient is said to have a positive Rough-Sink sign. Then we have another sign called the psoas sign. So psoas sign, you ask the patient to relax, and you, the clinician, would extend the right hip joint. When you extend the right hip joint, the pain in the right iliac fossa worsens. Then there is another sign known as the obturator sign. And so you, the clinician, would ask the patient to relax, and then you would flex the hip joint and internally rotate it. Once you do that, the pain intensifies. There is also another sign called the pointing sign. You ask the patient to point to where the pain is, and the patient points to the right iliac fossa. But these are not used to diagnose appendicitis anyways, but there are signs which can be positive in a patient with acute appendicitis. Very good. And so let's look at our last question in the clinical vignette. The last question says, outline your management for this case. And so for this case, we need to admit the patient and keep the patient nil peros. The nil peros is to prevent potential aspiration during anesthesia, if general anesthesia might be required at some point, but we keep the patient nil peros. Then we take blood for the investigations we've listed, like the full blood count, grouping and cross-matching, blood urea creatinine, and then we adequately resuscitate the patient with fluids. If the patient is dehydrated, maybe from the vomiting, you adequately resuscitate the patient, correct any electrolyte imbalances, and then once the diagnosis is established, we can give adequate analgesia to make the patient feel better, and then consult surgery. So urgent surgical consult for emergency laparotomy, and then the procedure we are going to do is likely to be appendicectomy. And so thank you for watching this episode. Our reference was Badger. Like we've said, that for surgery in tropics, we'll be using Badger and other books like Farkassen, Schwartz. I decided to state the reference here so that you know where we got our answers from or ideas from. They were not concocted. And so once again, thank you for watching. Please do not forget to like and share this video, and then subscribe to the channel if you have not done that yet. And so see you in our next video. Until then, adios. Bye.